Good afternoon, everyone.
Good afternoon.
Good afternoon, Dr. Sudhi. So we shall begin
Nice to meet you, Penny. Yeah.
Nice to see you again. We shall begin the webinar now, okay?
Okay, yeah.
So this webinar is brought to you by the De La Salle University Southeast Asia Research Center and Hub, or SEARCH, in partnership with the International Studies Department and the Political Science and Development Studies Department. This event is ASEAN and COVID-19 Select Country Situationers in celebration of ASEAN Month 2021. Now, the views expressed in this webinar are those of the speakers and do not necessarily represent the views of the Southeast Asia Research Center and Hub. Allow me to introduce the Department Chair of the International Studies Department, Dr. Elaine Tolentino, to deliver the opening remarks. Dr. Tolentino.
Thank you, Fernie. Dr. Ferdinand Santiago, to our invited panelists, to our students and guests. It is my pleasure. Again, my name is Elaine Tolentino, and it's my pleasure to welcome all of you to today's session. So as Fernie mentioned earlier, this month of August, we commemorate the establishment of the Southeast Asian nations, or ASEAN, and to celebrate the search together with the International Studies Department and the Political Science and Development Studies Department, we are hosting this webinar titled ASEAN and COVID-19 Select Country Situationers. And this is very timely because we all here we are all witnesses to the unprecedented impact of the pandemic. As of today, there are more than 200 million cases worldwide. It's one of its most recent variants. The Delta variant has already penetrated many countries in the region, in the Southeast Asian region, and countries that have successfully flattened the curve are now experiencing surges in cases, like Vietnam, Thailand, Manila, the Philippines rather. Meanwhile, and I don't want to preempt, just recorded its because Ador will talk about this later on, I'm sure, has recorded its highest cases yet as of yesterday. So so this is very timely, as I said earlier, for us to have this conversation with our panelists here. They will try to critically assess what is happening in the respective countries' current situation. So without further ado, again, I welcome everyone, all of you here. Now I turn over the floor to Fernie.
Okay, thank you, Elaine. Before I introduce our moderator, allow me to read the abstract of this afternoon's webinar. COVID-19 affects every country in Southeast Asia, where in the past month, the infection rate has skyrocketed with record high case numbers. As nations face the increasing spread of the virus, more contagious variants, and slow vaccine rollout and engagement, lockdown measures have been implemented to control the situation. Now, this webinar brings together scholars from the region to conduct a critical inter-Southeast Asia conversation on COVID-19, existing conditions in Cambodia, Indonesia, Malaysia, and the Philippines shall be presented and analyzed from the ground level perspective. Now, our moderator is a geographer whose research interests involve transnational migration and emotional geographies. Prior to going to Singapore for her doctoral studies at the National University of Singapore, she taught at the Department of Geography of the University of the Philippines, Diliman, where she also obtained her BSc and MSc degrees in geography. And she's currently with the International Studies Department of De La Salle University. So without much further ado, ladies and gentlemen, Dr. Evangeline Katigbak Montoya. Vanji?
Thank you, Dr. Fernie, and a very pleasant afternoon to everyone. Like what Dr. Fernie has said, we have with us 4 scholars who will be sharing relevant COVID-19 situations in their countries of expertise. And each speaker will have 15 minutes each to present. And after all of them have presented, we will open the floor for questions and comments. Now, our first speaker is Dr. Sudhir Manasir. He is a senior lecturer and researcher at the Faculty of Public Health, Universitas Hasanuddin in Makassar, Indonesia. He has conducted research on various issues related to drug use and HIV/AIDS in Indonesia. He has been involved in drug use and HIV prevention programs in Indonesia since the mid-1990s. He also serves as vice president of the Indonesian Young Academy of Sciences and is a 2019 Eisenhower Fellow for their global program. He has a Bachelor of Medical Sciences from the Universitas Hasanuddin and a master's degree and PhD from the Melbourne School of Population and Global Health at the University of Melbourne. So everyone, let us all welcome Dr. Nasir.
Okay, thank you very much, Dr. Evangeline. And I would like to express my gratitude to colleagues in Manila who is inviting me to participate in this valuable and timely sessions talking about COVID-19 in the region. And my topic today is COVID-19 in Indonesia, and I would like to try to discuss several trends or milestones of the pandemic in the archipelago from last year, January, February 2020 to the current situations, August 2021. Next slide, please. So as many of us have read and also mentioned by Dr. Evangeline, that most countries or all countries in the regions are severely hit by the pandemic. And Indonesia is no exception, even actually among the most severely hit by the pandemic in Southeast Asia. And especially since May 2020, we start to see the significant increase and skyrocketing of the confirmed case as well as the fatalities. And mass media, traditional media or mainstream media as well as social media use the term second wave. Even though actually if we look at this graph, it is very difficult to differentiate the first wave of COVID-19 in Indonesia and the second wave, especially since May 2021. What we are seeing in this very simple but very representative to the current situations in Indonesia is the fact that it is a rapid and also exponential transmissions, and actually a constant rapid exponential transmissions since 2021. There was a bit of window of opportunity between January to March, but unfortunately we didn't manage to use those window of opportunity and momentum to better manage the pandemic in the country. Next slide, please. And to provide some basic data or very relevant data related to COVID-19 in Indonesia at the moment, per 30th of August, we can see that there are more than 4 million of confirmed cases. And more important than the confirmed case is actually the death or the fatality rate, and also the positivity rate, which is more than 20%, to illustrate that actually this official recorded data is most likely merely the tip of the iceberg because of two things: the limited testing ratio, and also the limited tracking capacity. So we need to see this formal official data into a critical lens. And also, as I have said, this is among the most severely hit country in the region by the pandemic. And there are several factors that we can take into considerations why Indonesia experienced this constant wave of COVID-19. The first one is, I think, and many there are increasing study reports at the moment, is the government denial attitude in January and February 2020. This denial attitude happened, even though there are many scholars, those from medical and public health, epidemiological background, try to advocate the government about the urgent threat of COVID-19 since December 2019. But most of those suggestions end up without significant follow-up. And also we can see, particularly in the beginning of the pandemic, the tendency of the government to put economic issues, including economic growth, the very basic characteristic of the current Joko Widodo's administrations and priority, into the top priority, while sacrificing many essential measures to contain the pandemic. And because Indonesia is geographically a large country, consists of more than 400 cities and districts, the uncoordinated responses between the national, provincial, city, and district government also contribute meaningfully to the slow response and scattered response of the government. And we also see weak risk communications. So it is very hard for the people on the ground to grasp and to adhere to protective measures, while the high-ranking officials produce contradictory messages to the public. And also, of course, the infodemic in the current digitalized world, the misinformation and disinformations related to COVID-19 spread widely in the country. Next, please. And in relations to fatalities or the death, we can also see some biomedical and also social vulnerabilities that may assist us to understand the high rate of death and emergency related to COVID-19, particularly two non-communicable diseases, which is cardiovascular diseases and also diabetes mellitus. And this is very closely related to two risk factors that are sharply increased in Indonesia, and most likely actually in all countries in Southeast Asia. Hypertension and obesity that we can associate with the significant social and economic changes since 1980s that also affect the way people do their daily life, the food consumptions, and also physical exercise. And in Indonesia, we have this basic health survey that can illustrate, that conducted every 4 years, to illustrate the increase, the sharp increase of these comorbidities that significantly contribute to the high fatalities, particularly among peoples with already compromised immune systems, and also the elderly, because of the increase of life expectancy. Indonesia's life expectancy at the moment is 71. So we have significant number of people above 65 years old. And people living with disability, children, and also to provide socioeconomic determinants, also people who live below poverty line and those who are vulnerable to poverty. And for Indonesia's situations, also those people living in remote areas, in small islands, and in the hinterlands. Next slide, please. I have mentioned several comorbidities that most likely contribute to the high death, and this is the illustrations of the significant increase of hypertension in the regions as recorded in Indonesia's basic health survey. And next, please. And this is the obesity. So basically, COVID-19 take place in the globe, where actually there are another parallel pandemics that happen. Hypertension and obesity, and those parallel or twin pandemics tend to exacerbate each other. People living with hypertension, people living with obesity or with cardiovascular diseases or with diabetes mellitus tend to experience more severe clinical symptoms and need hospitalizations and most likely to die because of COVID-19 compared to people without comorbidities. Next, please. And also the contributions of the weak or vulnerable health system. This is to provide the audience of this webinar about the current Indonesian's health system. Particularly some basic illustrations how the hospitals and health facilities are overwhelmed by COVID-19 patients. We only have 4 doctors and 12 hospital beds for every 10,000 people, and for intensive care beds per 100,000 people, it is only 3. So you can imagine when the COVID-19 cases are skyrocketing, and the queue to get a room or intensive care unit in health facilities will be very fierce and put health workers in a big dilemma, especially in relations to the utilities or the usage of basic life-saving facilities such as ventilators, oxygens, and so on. And COVID-19 actually also and the overwhelm of our current hospitals and health facilities contribute to the high fatalities among doctors and health professionals in Indonesia. There are more than 400 medical doctors died in relations to COVID-19, and some of them are actually my colleagues, my close friends in Makassar, South Sulawesi, including also among nurses and other health professionals. Next, please. And of course, I don't want to provide all gloomy indicators. There are also several progress. Since February 2020, the rollout of vaccinations started in Indonesia. And this is, of course, an important milestone. But these vaccinations also face several challenges in relations to the availability and the constant availability of vaccine. We experienced some shortage of vaccines in the last few months. And another factor that also contributes to the still low coverage of vaccination is vaccine hesitancy. And this is closely related to hoax, to misinformation in relations to COVID. Some basic data such as we can only manage to provide around 29% vaccinations, the first dose, around 60 million people, and the target population that we should vaccinate to achieve the so-called herd immunity is at least 208 million people. Those who got the complete first dose and second dose of vaccinations until yesterday, we can only manage to reach around 16 to 17%. Some good news also, the supports of religious groups, Muslim groups, and also Christian groups in Indonesia to promote these life-saving health programs. Even though they are not homogeneous groups, some of them provide more consistent support and some others more ambiguous or sporadic support. And some milestone also related to the surge of the case in relations to Idul Fitr, or the festival after the holy month of Ramadan in May 2021, and then the emergence of Delta variant. They really caused sharp increase of cases and also deaths, both in Java and outside Java. And now, while some good measures, we achieved many good progress in Java and Bali, we start to see also the increasing cases in Indonesia's hinterlands. Next slide, please. Yes, 2 minutes. Only a few slides remain. And to get some of colleagues here, I know, come from history background. To get some historical comparisons, we can compare the current epidemic or pandemic with the Spanish flu pandemic in the past. They also spread not just to the large cities in Java, but also to the hinterlands of Indonesia, including in Makassar. Makassar is the largest city in the eastern part of Indonesia, and this was also the gate of the Spanish flu that take 1,000 lives in the archipelago. Next slide, please. Not just Makassar. Makassar is, of course, a large city. This is Toraja, who is quite far from Makassar. Even today, we need to have like 9 to 10 hours by car or by bus to reach Toraja, but there are several historical records how Spanish flu hit Toraja severely. And also there are still many elderly people who remember those gloomy days, and also the use of local word to illustrate the severity of a Spanish flu epidemic. They use the local words of Rababiang, means the plants that destroyed by typhoon. Next, please. And this is my last slide. So there are several things that we need to take into considerations in Indonesia to better manage the pandemic. The first one is to strengthen the national and subnational government coordinations in relations to COVID-19 prevention and care, and also to improve the quality of risk communications, to convince the wider public to comply to protective measures, and the transparent of the data in order to overcome the infodemic. Without transparency, people tend to doubt or to distrust government's suggestions. And also participations of the civil societies, religious organizations, and private sectors are very important because of limitations of resources of the government. And also the moratorium of political rivalries, because political rivalries still take place amidst the pandemic, and it is actually slowing the responses. And the last one is, this is really a good time for the government to realize the strong evidence of the urgent need to strengthen two things to enable us to better prepare against the pandemic now and in the future, which is science ecosystem and also strengthening health system. Next slide. It is only some picture. Yeah, thank you. Terima kasih, and stay safe and well to all audience of the webinar this afternoon. Thank you.
Thank you very much, Dr. Nasir. We will be moving on from Indonesia. We will be moving to Malaysia, and we will learn from from our second speaker, who is Dr. Por Hyong Hong, who is a lecturer at the School of Social Sciences, University Science Malaysia. She uses a wide range of conceptual and analytical tools from across various disciplines in the field of social sciences to interrogate issues pertaining to medicine, health and diseases, bodies, modernity, and nationalism. Recently, she has also developed interest in the politics of culture and politics of memory. Her geographical focus is mainly Malaysia, Southeast Asia, and East Asia. So everyone, let us welcome Dr. For Hyung Hong.
Thank you, Dr. Evangeline, for the introduction, and thanks, Glasael, for having me today. I need the host to assign me as the host so that I can share my screen. Because okay, yeah, now I can share it. Just now I couldn't. Can you see my slides?
Yes.
Okay. It takes it's a bit slow here. Okay. Yeah. Great. Thanks again for having me today. So I'll talk about the situation in Malaysia. Basically, I'll try to start with Malaysia's healthcare system in order to give you a picture of where we stand at the moment. So Malaysia's healthcare system, actually, we have two comparatively strong health sector. One is the public health sector that is heavily subsidized by the government, and the fully profit-oriented private health sector. So from public health sector, actually, it takes up the national constitute about over 50%, slightly over 50% of national health spending, fluctuate between 51 to 54%, whereas the private health sector constitute about 46 to 49% of national health spending. And the share of government government health spending of general government spending is about 6%, but has recently increased to almost 10%. And that is also the background where you see that Malaysian government has been talking about reforming the healthcare system, especially in terms of the financing system. And in terms of hospital facilities and resources, the public health sector controls over 144 hospitals nationwide, or over 42K of hospital beds. And this network of hospitals, they are also connected with another network of government clinics, which is over 1,800 health clinics nationwide, and some mobile health services in remote areas, especially in Sarawak and Sabah. Whereas in private health sector, we have over 200 hospitals and about 16,000 hospital beds. And in terms of manpower, there are over 48,000 medical doctors work in the public health sector, of which 23,000 are contract doctors. I'll come back to these contract doctors later, because something interesting happened just a month ago in July. Whereas in private health sector, we have over 15,000 medical doctors serving in the private health sector. And in terms of workload, actually the public health sector shoulder a much heavier workload comparatively, in relative to their private counterparts. The public health sector, they take care of over 2.6 million of admissions, whereas the private health sector only about slightly over 1 million admissions every year. But when it comes to outpatient, you can see the proportion is very the gap is very large. The public health sector, they are taking care, processing 46 million outpatients per year, whereas for the private sector, it's just about 3.5 million. So it's almost more than 10 times what we can see, the workload of the public health sector. And in terms of per capita spending, the government spent over 600 per capita in purchasing in PPP purchasing power parity, yeah, in 2019. That is the latest data that I can get. So it is actually the third highest in Southeast Asia after Singapore and Brunei. But with this much of resources, how has Malaysian government been doing? How has Malaysia been doing over the past 2 years in handling this COVID-19 pandemic? Now I'll turn to look at how we handle this pandemic. So this is an overall picture of where Malaysia stands. You can see here we are not doing very good. If we just look at the absolute numbers, Malaysia is not the worst. And it seems to be getting better. But then if we look at the number in relation to the population, the number of population, the size of population, then Malaysia is the worst among Asian countries. You can see from this graph, which I get from our World in Data, even though we were doing pretty well last year, but beginning from April and May this year, we are doing really badly. And the worst is actually, I couldn't say that it was the worst, but then we hit almost 25,000 cases per day on just about a week ago on the 26th of August. That was the highest ever recorded. Whether or not we will climb past again that benchmark, the 25K, I don't know. Let's wait and let's see in the coming months or weeks. Huh? And in terms of death as well, in relation to population, Malaysia is not doing very well. As you can see here, this graph which compares all countries' performance in terms of death per million. Malaysia is the worst in the ASEAN country. And then in terms of tests conducted per confirmed cases, Malaysia was doing very well last year. But then you can see beginning from about September and November last year, when we had the drastic surge of infection cases after Sabah election. And then the test conducted per confirmed cases has dropped a lot, okay? And it's not catching up over the past 12 months. Singapore is the country that has done the best in terms of this indicator. And in terms of vaccination, so far, until as of yesterday, we have over 45% of the entire population are fully vaccinated. And then in terms of adult population, they are already 62% fully vaccinated. So in terms of vaccination, we are not doing that bad. But in terms of other indicators, we are doing really rather badly. And this is an overall picture of what happens over the past 18 months. As you can see, when the pandemic was unfolding, the political development wasn't very stable. For those who have been following politics in the region, especially for politics in Malaysia, you would notice that last year in February, the last week of February, we had a political coup, which ended up in a change of government in a very untimely time, okay, because the pandemic just started. But then interestingly, the second wave that came in mid of March, the first wave would be the first wave as people I think different experts or different people identify this first wave, second wave differently. Okay, the phasing, different people kind of like did the phasing differently. But according to one of the experts, his name is Amar Singh. He's a medical doctor. He kind of like identified into 4 waves. The first wave was actually when the first case detected in Malaysia. It was on 25th of January 2020 last year. And the second wave came in around early to mid-March, which was associated with a mega religious assembly taking place in Kuala Lumpur when there was when the political coup was taking place. Because of the political coup, there was like leadership vacuum and also executive kind of like oversight because people were too distracted by the political coup that nobody kind of like paid attention to the fact that there was this huge assembly, mega assembly. Usually with that kind of, the size of that kind of assembly, usually you would need a permit from the government. But then that assembly completely went unnoticed until the first case, COVID case associated with that assembly was detected first in Brunei, and then Brunei informed Malaysia government. Then that's how we started the second wave in Malaysia. So, but during this second wave, the new government, we call it Perikatan Nasional, took over, and then immediately started this so-called nationwide lockdown. We call it MCO1, Movement Control Order, the first phase, the first ever lockdown on mid-March. The lockdown lasted for 12 weeks, altogether 12 weeks, and then ended in mid-May. The lockdown was very successful because it does bring the case under control, and then we reached 0 case per day, 0 case per day on July 2020. So during that period of time, you can see that there was this opinion poll conducted by our Department of Statistics and also conducted by a poll company, shows that the Perikatan Nasional's the satisfaction rate of the Perikatan Nasional, the popular response was actually very good. More than 60%, nearly 70% of the Malaysian population were very happy with the Perikatan Nasional government's performance. Okay, so then, but then we immediately went into the Sabah election soon in September, and during this period, Malaysia was still doing very well, and as we can see, holding election is will not necessarily cause any outbreak. If we look at the situation in South Korea and Singapore, these two countries, they also had election. Somehow they have general election, the nationwide kind of election in their country. No outbreak was related to the election, but then it was very different. The situation was very different in Malaysia, especially during Sabah election. There were already some warning from public health experts. The warning came from public health expert that there are several small community outbreak in Sabah. So regardless, if you have movement of people, it's safer to impose quarantine, compulsory quarantine for people flying back and forth between East and West Malaysia. But then the government was very complacent because the outbreak was already brought under control. So there was no quarantine at all. And until the very last day, on the very day of election, after the election, immediately after the election, the next day, then the Ministry of Health finally imposed lockdown, but it was already too late. It was already too late because immediately from October onwards, the so-called third wave came, and this third wave was really, really very strong, and supposedly, in view of such a strong surge in outbreak, surge of infection, why was there no lockdown following Sabah election? Because back then, during October, basically from what we can observe on social media as well as on media, the popular opinion was against another lockdown. So the government was kind of like trying to test the water, to test where the air blows as well. And so they didn't impose any lockdown, despite that the third wave related to Sabah election was so much more strong than the first or the second wave. So no lockdown. So the situation continued to really worsen until a year later, that would be 2021, January, the government finally imposed a second lockdown. but it was only partially implemented in the most severely hit areas or states like Selangor, Sabah, and several states. Not a nationwide lockdown like we had back in March 2020. So that's basically the unfolding pandemic and the unfolding political coup. But the political coup, there were in Malaysia there was a proclamation of emergency together with the imposition with the MCO, Movement Control Order. So on 13 January, our Prime Minister declared emergency. Actually, there was already an attempt to proclaim emergency back in 2020 October, but the first attempt didn't go through because the king didn't agree. But then the second attempt, the king approved. Our Prime Minister back then it was Muhyiddin Yassin who was the Prime Minister. So he applied for the proclamation of emergency. So the second attempt was approved by the king. So Malaysia went into emergency, was under emergency beginning from mid-January and lasted until 31st of July. So, and basically, there are 5 anti-COVID strategies, government responses to this COVID pandemic. So the first was movement control, and then the second will be contact tracing through an app called My Sejahtera. And there were also economic stimulus package, which the government give cash handouts to those, so we call it B40 families and households, and also allow workers to withdraw their retirement fund. We call it EPF funding. And then another strategy will be the proclamation of emergency, like I mentioned before. And then the final one will be vaccination. Vaccination was perceived as a strategy to exit the pandemic. So this is what I have just mentioned earlier, all what happens along from beginning from last year until recently. So, and then, but this year we have another wave, it's the 4th wave, beginning from mid-May, which was associated with holidays and considerable movement of people. The holiday was actually the Ramadan month, and Ramadan wasn't really a holiday, but the Idul Fitri celebration, because this is already the 2nd year of pandemic, right? Actually, people were banned from doing business back in 2020 when we were under lockdown, the first lockdown. All traders, no one was allowed to do business. But then actually Ramadan Bazaar is very important for Muslim traders. It is one of the yearly season that small traders can make the most out of their business. Yet they were banned in 2020, and when it comes to 2021, the government was actually reluctant to kind of like offend them for a second time. So there was no ban, but then quickly Ramadan Bazaar was allowed. Only halfway through, it was banned again because there were too many cases associated with Ramadan Bazaar. So that brings the 4th wave because of the considerable movement and contacts between people during all those festive months.
I'm sorry, Dr. Por, can we wrap up the presentation?
Okay, sorry.
Thank
so
you.
I'll just go to the concluding remarks. So in Malaysia, this public health crisis is supposed to be a crisis to be managed, but at the same time, it was also a crisis to be instrumentalized by a very unstable government who only have a very thin majority because of the coup, taking over from a government which got its mandate from the last election. But then the Perikatan Nasional didn't really get that mandate, yet they grabbed power from the previous government. So and the second reason that Malaysia has been doing rather badly after Sabah election was because of the competing priorities between Ministry of Trade and Ministry of Health. The Ministry of Health wanted to take care of people's life, but then the Ministry of Trade wanted to take care of economy, of businesses. And the suspension of parliament as well, that means there was no transparency, there was no democratic procedures in terms of the governance of COVID-19. So, and eventually the poor governance result in the collapse of our very good public health system. And yeah, so the lesson from Malaysia is that governance and leadership are as important as availability of resources. Even though Malaysia is blessed with such a resourceful public health system, yet we govern so poorly over the last 12 months. Thank you.
Right, thank you very much, Dr. Por. So from Malaysia, we will be hearing from a Cambodian scholar, Mr. Kim Kong Heng. He is a doctoral candidate in education at the University of Queensland, Australia. He is also a visiting senior fellow at the Cambodian Institute for Cooperation and Peace and a co-founder of the Cambodian Education Forum. He has published several journal articles, book reviews, and opinion pieces. His op-eds have appeared in East Asia Forum, The Diplomat, The Interpreter, Nikkei Asian Review, and the Phnom Penh Post, among others. Everyone, let us welcome Mr. Kim Kong Heng.
Thank you so much. And I'd like to say thank you to Dr. Fernando for inviting me to participate in this webinar, and thank you for having me. So I'm really excited to share with you COVID-19 situation in Cambodia. Although at the moment I'm living in Australia, which is a good place to live during the pandemic, I have been following situation in my country closely, and especially last year. So last year, one keyword to describe COVID-19 situation in my country was success. So we had a great success containing the spread of COVID-19. You can see in the graph here from around February 2020 until February 2021. So one whole year, we don't really have many cases. So cases started to soar in March 2021. So last year, COVID came to Cambodia in January. So we had the first case in January. So cases keep rising, but not a big number. And we had the first community outbreak in November. So we kind of control COVID-19 for 11 months from January to November. So at the end of the year, at the end of last year, we had around 300 cases. However, there were only 4 active cases at the time. So most of the cases had recovered. And at that time, a lot of people have written to explain why Cambodia, as a small country with very limited resources, poor healthcare system, can cope with COVID-19 better than other countries in the region or in the world. So there are many factors at that time. I have written a few articles, a few commentary as well, explaining why COVID-19, we had COVID-19 success. So there are some of the factors here. We have COVID-19 measures, so a lot of measures taken by the government, testing, contact tracing. So these are the measures that are commonly used by other government as well. But why similar measure but have different results? So there are more factors like solidarity and cooperation. We have got a lot of support from WHO and development partner. We have donation from local people, local actor. And another factor is about demography. 80% of Cambodia population live in rural area, and most of the cases happen in the city where there are many people. So it's kind of lucky for this kind of demography, and we most of the people in Cambodia are young, under 35, because we had 40 years ago we had a purple regime which killed a lot of people. So people were born after in the 1980s. So most of them are young, like including me as well. There are other factors as well, like leadership factor. So we have quick decision because the government. This is about politics. We had a major opposition party which was dissoluted in 2017. So only one ruling party. So all decision making could be very quick. So this it was helpful for a situation like COVID-19 that government can act quickly, decide quickly. And some people there also talk about luck. This is just simply luck. So there are many factors contributing to success last year. However, in this year to 2021, things changed. I think as a previous speaker have presented, there are similar situations across Southeast Asia. That last year we did a little bit better, but starting 2021, more infection, more death. So this is the case for Cambodia. You can see the graph here from February 2020 until February 2021, one whole year, nothing much happening. But starting in March until now, there were a lot of cases. And you can see on the table here, at the moment in April, there have been around 400 to 900 daily cases. So every day we have new cases around 400 or 500. So today we have 400 plus. In July, almost one whole month, we have around 800 to 900 cases. And this is a lot for Cambodia with a population of 16 million people. And now every day we have around between 10 to 30 people who die every day. For last year, no one died of COVID-19. Starting in June, 10 to 30 people died. But luckily, at the moment, the rising infection and deaths keep decreasing thanks to vaccination program that I will talk in a minute. So as of yesterday, there were around 92,000 cases, and 60% were imported cases. Last year, most of the cases were imported cases, but this year, most of the cases are locally acquired. So far, we have almost 2,000 deaths. And it keeps increasing, I mean, it keeps coming because 10, 20, 30 people die every day, which is very worrying. So this is Cambodia compared with other Asian countries. Laos and Brunei can do better than other countries. Last year, they record, I think, 0 cases almost every day, but now we have every country has new cases. Cambodia was below Singapore last year. So we were like numbers 8 doing better than other country in terms of total cases. Now we move up to about Singapore. So you can see here, because Indonesia, Philippines, so these are the countries which have a lot of people. So we can expect that they have more cases. So the number of cases you can see here is very alarming, especially for the Philippines at the moment. This is yesterday data, 22,000, and Cambodia have 400 cases. So what have gone wrong since 2020 until now? So there are a few factors that can explain the situation, the current situation. Firstly, it's quarantine breach. So Cambodia did very good last year, but in February this year, we have a quarantine breach. So people who were in quarantine that did not wait until 14 days, they escaped the quarantine. So they give money to the security guard, and then they can get out of the quarantine hotel, go clubbing, go to karaoke, go dancing, for example. So there were this situation that people escaped quarantine, went to club, and just spread COVID-19 to everyone in the club. And by the time the government know this, it had been like 10 days or 2 weeks already at the time, as I remember, like 2 weeks already. So the government start to contract testing, but it was too late because it has been 2 weeks already that the case has spread widely across the city. And it was not a normal variant. It was a UK at the time, the UK variant, which was more contagious. Later on, we have data which is happening across Southeast Asia. So it's still hard to control. So another factor is failure to act quickly and decisively. Actually, previously we can act quickly, but why this is not act quickly? Yeah, we still can act quickly, but not quickly enough. It's like we know the thing is too late. Like before we know that, oh, this is the first community outbreak. Before we know this is the outbreak, it happened like 2 weeks already, so it's late. And we, at the time when we found we faced the outbreak, the government did not apply lockdown immediately, impose lockdown. So they wait until the situation is unmanageable. The government start doing lockdown, and it was a last-minute lockdown. They announced that, okay, everybody, we have lockdown tomorrow, and they announced this evening. People start panicking, they're panic buying, they went out and buy, so they meet each other. After that, the case start increasing again because of the situation that people start panic buying, they meet each other, they went shopping. Later on, the government imposed lockdown, 2 weeks, 1 month lockdown. But while people were in lockdown, we have a red zone, yellow zone, and orange zone at the time. So people who were in red zone, they cannot go out of their zone. They have to stay in their zone. And after 2 weeks, people start posting video that they're running out of food. They cannot survive. Now it's not dying because of COVID, but they're dying because of having nothing to eat. And then because of this situation, the government decided, okay, no more lockdown. You can go out wherever you want, but it's not, okay, that you still can go out, but restricted within your area, for example. So the situation now rely on individual people who have to protect themselves. Okay, so many cases have been reported, several hundred every day, 800, sometimes we go up to 1,000, then later on 800, so around that for a couple of months. And I think the beginning of this month, for 2 weeks, we had lockdown. Now it was just, it was lifted, but still the cases are still there, but it's better situation because of vaccination. So here are the current measures that to control COVID-19. Schools still closed. So school, university were ordered to close last year in March. Later on, it was ordered to open around, I think around November, and then it's ordered to close again. So close until now, even because case still, so there are still infection. So mass gathering still banned, restriction, travel restriction, domestically and internationally, that's still there. Testing, contract testing, and mass mandate, they are still required. Curfew lockdown, partial, it's not, before we have a city lockdown, citywide lockdown, now no more. But the special thing that now can help Cambodia to COVID-19 is vaccination program, and I think you are aware that we have a very good vaccination rate. So here is the vaccination. It starts since February. So coincidentally, it started when we had a major outbreak. So people get vaccinated. That's not, initially there were vaccine hesitancy, but later on, because we have a community outbreak, a lot of cases, people no longer think about vaccine hesitancy because we got vaccine from China. With a lot of people, they do not really trust the quality, the efficiency of the vaccine, but because they face lockdown and infection, they start getting vaccinated. So we launched our vaccination program in February 2021 to our population of 16 million people, 16 plus. And as of yesterday, 10 million people got their first dose of vaccine. So it's about 62% of the population. And 8 million people got, so 50% got 2 doses. We have 500,000 got third dose as a booster dose. Our plan is to have people between 18 and above, 10 million people get vaccinated. And as of yesterday, 90% of these people have been vaccinated. And we plan to vaccinate to 2 million people who are between 12 to 18. And so far, 74% were vaccinated. So actually, we plan to vaccinate people up to 75% of population, 12 million people, which is 75%. And we have done very well in that area. And where the vaccine came from, most of the vaccine from China. So we got some donation from China. I think donation, yeah, here you can see around 4 million dose donated by China and UK, 2.3 million donated by through COVAX facility by Japan and the US, and the rest we bought from China. So 18.5 million, 74% of our vaccine were from China. So we got some donation and also purchased from China. So basically, we have received vaccine from Sinopharm and Sinovac. Most all the vaccine are 25 million doses. So this is if I think about whether it's failure or success in terms of vaccine, we can say it's a success as a small country with the very limited resource, little money, but we still can secure a lot of vaccine, although it's not let's say the best vaccine from the US or other country, but it's still vaccine. So the best vaccine at the moment is the vaccine that you can get. So a lot of people say like that. So what are the factors that explain this? So these are the best practice I got from WHO. Let's say there are 4 factors: strong leadership and coordination. So coordination between ministry across the country, and part investment that has been a kind of functional public health system. So we got 3,000 people who have conduct contact tracing, and risk communication and community engagement. A lot of people, listen to the government. Before we have kind of this mistrust or distrust in the government, they don't believe it, but because the government can kind of control the spread of COVID-19, they start to believe in what the government is doing. So there communication between government, the public, and the government and the people getting better. And finally, again, international solidarity and cooperation. We receive support from UN and other partners like the US, China, and Japan, and UK, and other EU country. And we have also helped other countries as well. I think a few weeks ago, we sent some masks and to Myanmar, and before we have give some masks to other countries as well. So this is the end of my presentation, and a few references here, and thank you for your attention. Yeah.
Thank you very much, Mr. Heng. So we will move close to home. Our final speaker is Dr. Ador Torneo. He is the director of the Jesse and Robredo Institute of Governance. He is a full professor in the Political Science and Development Studies Department at the De La Salle University. He is a well-published development and governance researcher and practitioner with extensive experience in evaluation, public policy analysis, research, survey research, and public opinion polls, and data analytics in the Philippines, the ASEAN region, and South Korea. His interests include public sector performance management, electoral administration, comparative public administration, and international migration. You have the floor, Dr. Torneo.
Thank you very much, Dr. Katigbak Montoya, and thank you very much to our colleagues in Search International Studies Department and my department, Political Science, and to all of the speakers. No, I picked up a couple of things today, and I'm happy to share the case of the Philippines. I don't know if happy is the right word, no, but I'd like to share with you the current status of COVID-19 in the Philippines. So let me just set my timer so I can time. Okay. So let's just, this is the current case of the Philippines. We've had the highest recorded case yesterday, around 22,366 cases, and we are nearing the 2 million case mark. So we have around 150,000 active cases. Now, in terms of intensive care units, we are estimated to have around 74% of COVID-19 intensive care units occupied. And we are nearing the capacity threshold of many hospitals, in particular regions, including the NCR and several other regions. So our death rate is fortunately relatively low at 1.74%, but it's still unfortunate that so far we have had around more than 26,000 deaths since the pandemic started. So on a per population basis, the Philippines has the 4th highest COVID-19 cases in Asean. The situation has been very fluid, but just like our colleagues that presented before me, we are a bit skeptical in terms of the actual figures of COVID-19 because of the low testing in the Philippines, and the poor contact tracing makes the figures that we have conservative. The actual figures is most likely higher. This is where we are right now. So we have several quarantine classifications. We have what we call MACQ, GCQ with heightened restrictions, GCQ. These are a series of classifications with varying degrees of restriction in different regions all over the country. So this might be a little bit confusing, but please bear with me because we are also confused as to what this means. Now, originally, we had just had one classification. We called it General Community Quarantine, which is a state of lockdown where people are not allowed to go out of their homes except for essential workers and people performing essential things like getting grocery or medicine. When it was not sufficient, the government made a new classification called Enhanced Community Quarantine, which still puts some measures in place but relaxing measures. And then it was not enough. The government created MGCQ, or the Modified General Community Quarantine, followed by a Modified Enhanced Community Quarantine. And then we have General Community Quarantine with restrictions and General Community Quarantine with heightened restrictions. Personally, I could not keep track because beyond all of these restrictions, the government actually changes what it means. The Philippine government, the Interagency Task Force, is actually changing what this classification means. So it's a bit hard to keep track of what the specific measures are. But for now, we are highly restricted in terms of movement. The Philippines has one of the longest lockdowns. It's claimed the longest lockdown in the world, and it has become our go-to tool or mechanism in order to address rise in cases. So it's very expensive in terms of losses to the economy. It's estimated that we are losing somewhere up to around $3 billion a week, no, in terms of the impact of these lockdowns in the national capital region alone. This is just the national capital region of the Philippines. So it goes anywhere from half a million dollars up to $3 million a week. So just to show you what has been the impact of the COVID-19 pandemic is that the Philippines has had the highest economic contraction in Southeast Asia in 2020, and it's the worst since the Philippine government started counting in 1947. The Philippines is considered to be a highly vulnerable economy, and it's expected that the Philippines is one of the countries that will be last to catch up or to recover, especially given the current challenges of the Delta variant. The lockdowns have severely damaged the Philippine economy. Some of my colleagues call the lockdown a nuclear option because it's very destructive. It tends to result into closure of businesses, and without adequate government assistance and aid, it results actually in permanent closures. So many of the medium, small, and medium enterprises have already permanently closed, and this includes those in the field of tourism, small businesses, food industries, restaurant, and other small businesses. Now, going into vaccines and vaccination, the government of the Philippines is among the first that initiated vaccine procurement, but we are also among the last to actually receive vaccines in Asean. So a series of government blunders in terms of managing the vaccine procurement, and also a few concerns from among the pharmaceutical companies caused delays in terms of vaccine procurement. So just to show you, I don't know if this is still updated, no? Philippines is actually one of the last, if not the last, in ASEAN to receive vaccines, and the first set of vaccines are donations. But the thing is, we are also among the first to actually initiate purchases of vaccines, no, since last year. In terms of vaccination, we prioritize very similar to the WHO COVAX facility vaccination list, except that we also include in the priority, in addition to health personnel, also uniformed personnel, soldiers, police, who enforce many of the policies and the lockdowns and restrictions. But in the early rollout of vaccination, we've had several instances where government officials in high positions were jumping, what we call line jumping. No? They're getting vaccines when it was not their turn. No? And it has become very controversial, to the point that the World Health Organization COVAX facility has actually warned the Philippines that if the vaccination priority will not be followed, then we might be having problems receiving vaccines from COVAX. So as the vaccine supply eased, then the incidences have decreased, but we're also able to vaccinate a lot of those in the priority sectors. One of the biggest challenges that we've had is what we call vaccine hesitancy. Just to give you a backdrop, one of the main reasons why there's a very strong vaccine hesitancy in the Philippines appears to be a series of controversies where the head of the public attorney's office raised a very highly controversial and campaign against a previous vaccination program of the previous administration. The public attorney's office head claimed that the vaccine caused multiple deaths despite the lack of evidence and contrary findings by the health department, and it filed a very, very public case against the vaccine supplier. The implication is a lot of people were actually had hesitant. The rate of vaccination in the Philippines declined for regular vaccines, and there is a good case to argue that it also caused hesitancy in receiving any kind of vaccine, including the COVID-19 vaccines. So in terms of awareness and trust rating of vaccines, these are some of the one that we got around March this year. This is quite old, because vaccination preference or vaccination willingness and hesitancy tends to change with time. But we just wanted to show that in here, there is a very strong concern among those who opt not to get vaccines about safety And a lot of it has to do with many misinformation and false information that are proliferating online. No, this is in addition to the previous government campaign against the anti-dengue vaccine that also caused a lot of Filipinos to have doubts about the safety and efficacy of vaccines. So we showed that in one of the recent paper, the trust in vaccines, perceived risk of contracting the disease, and vaccine history are salient predictors of vaccine willingness. In another study that we have to be published next year, but available already, trust in government, trust in the healthcare system, and trust in the vaccine itself were significant predictors of willingness to be vaccinated. Now, in the case of the Philippines, the president enjoys a high trust rating, but the same cannot be said. There are conditional findings of trust in terms of vaccination, where the vaccine comes from. No? For example, initially, many Filipinos were hesitant about vaccines from China, particularly Sinovac vaccines. And the vaccine willingness tends to drop when the brand of the vaccine is changed. For example, from Pfizer or AstraZeneca to Sinovac. So the only good thing is that vaccine hesitancy and vaccine unwillingness is not a permanent thing. And that in September last year, around 31% of Filipinos were not willing to get vaccinated. In around February this year, around 46% were not willing. No, in also around March, 61% were not willing, but the numbers is appearing to ease up. No, a recent survey in June says that around 45% of Filipinos are now willing to get vaccinated, and those unwilling to get vaccinated also dropped, no, from 35% to 35% in May, from May to June 2021. So in terms of vaccination, the Philippines is third in terms of vaccine doses administered, nominal counting. In terms of per population, it's quite low because the Philippines is the second largest country in ASEAN, no? After Indonesia in terms of population. So if we count by population, the rank of Philippines drops to around sixth or seventh, no? Seventh country, no? There are still some challenges in terms of rollout, and the challenges include the vaccine supply, but also the capacity of the Philippine government to administer vaccines. We have quite low capacity to administer vaccination, and the variation in terms of how systematic the vaccine rollouts are done in some places also cause some variation in terms of our ability to vaccinate the population. But right now, I think there's not much problem in terms of people who are willing to get vaccinated, but there are still challenges in terms of supply and our ability to vaccinate. So some of the challenges that we have is even after it's almost now 1 year and 4 months, the Philippines still has limited testing capacity. We do not have a coordinated and fully functioning contact tracing system. No, our government contact tracing app is not really that widely utilized. Our quarantine and isolation system does not appear to be work, including in the ports and airports, as shown by the easy transmission and the, we practically import every kind of variant of COVID-19 that there is that immediately gets into the Philippines, no, and that shows the weaknesses in terms of how we handle triage and handle the entry and departure of many people who travel to and outside the Philippines. One side says that the Philippine national government has effectively securitized the handling of the COVID-19 pandemic and primarily employed lockdowns as primary instrument. So you see a lot of uniformed personnel, you see guns on the streets, even if we know that guns will not do anything for the virus, but there is a very strong tendency to depend on the military, police, Coast Guard, and uniformed personnel to enforce. And while this is understandable, especially at the early stages of the pandemic, because they are the most organized and most easy to mobilize, our continued dependency on this kind of approach is being questioned. So in terms of the health system, our health system remains weak and riddled with unresolved problems and issues more than 1 year into the pandemic. The nurses groups claim that more than 30% of nurses have resigned since the pandemic began, and many of the nurse groups are threatening to mass resign in response to the government's failure to provide them with good pay and to provide the promised allowances for them. So the private hospitals are also threatening to disengage with the government health insurance body because of complaints over billions of pesos on the unreleased payments, and several hospitals were reported to have already closed because of the unpaid bills. Now, in terms of hospitals and isolation facilities, at present, because of the Delta variant, they are at or near full capacity, and the problems are not exacerbated not only by lack of facilities but also lack of health personnel to staff them. So the Philippine COVID-19 response is largely led by retired military and police generals, and it did not really work out very well. Most of the actual response, however, is done at the local government level, but many of the policies are made at the national level with these generals who are a very good, good military track records. But in terms of dealing with the health pandemic, none of them actually has backgrounds on this. Our health secretary is under continuous criticism for first downplaying the threat of COVID-19 pandemic, and then later on saying that we have addressed the issue, and then later on a lot of controversies regarding how the health department has been dispersing the budget. No, so the last development is that the audit issues of the health department, the health secretary said that after he clears the audit report, then he is leaving his position after many months and more than 1 year of the president fighting to keep him in place. So the president continues to display lack of coherent strategy and issue problematic remarks, but he remains highly popular. No, the president gave an initial assurances that there's nothing to be scared of during the early days of the pandemic, and then a lot of very controversial statements. For example, shooting quarantine violators dead, jailing people who refuse to get vaccinated, and telling the Commission of Audit to stop auditing and making their audit reports very public. So very in a way, the president gives us no clear sense of direction, and the remarks are actually causing a lot, not confusion, but also tends to be polarizing. But like I said, he remains highly popular. No? So these are the last few slides. Some of the concerns that we have is we are heading to an election next year, a presidential election. And some of the major challenges that we have is in terms of voter registration. We have lost 8 months of voter registration, and many of those who are eligible to be voters had not been able to register or did not register, either because of safety concerns or because of the COMELEC has postponed voter registration. So there are, of course, a lot of health threats, administrative and logistical challenges. Those who had been deactivated for voting unable to renew or activate their votes. And we are very concerned that not only about the health, but also in terms of the presidential election, whether or not there will be enough Filipinos who will be able to cast their votes. So there are also concerns that vaccines and government aid might also be politicized as a tool to get elected, no? And abuse or misuse of pandemic restrictions. For example, so it might be used against those who are opponents. No? Political opposition might be restricted from holding campaigns. There are these concerns. And the biggest concern of all is a massive disenfranchisement of voters. So this is my last slide. There are many challenges that the Duterte government, the Philippine government are facing right now, but many are problems of its own making. Vaccine hesitancy was largely prompted by government handling of the previous vaccine controversy. And a series of mistakes undermined public confidence and trust in vaccines. It also complicated vaccine purchase from suppliers because they were not willing initially to sell to the Philippines unless the Philippine government makes assurances that they will not be sued. No? And there are plenty of uncertainties while waiting for vaccines, as rising cases, limited testing, weak contact tracing, and the weak health system forces the Philippines into perpetual cycle of economically destructive lockdown. There's a concern that poverty and hunger might actually cause more people to suffer and die than the virus. No? And outside of waiting for vaccines, we do not see any coherent strategy on how the Philippines is supposed to navigate and exit this pandemic. No? The president and the IATF has not been very clear. We try to adapt, kind of make policies as we go along. But in terms of overall strategy, recovery plan, it's not very clear to us. No? And lastly, I'd just like to point out, though, that in fairness to the Philippine government, the COVID-19 pandemic is one of those that we in political science and public administration characterize as a wicked problem. It's a problem that's difficult to solve because of incomplete, contradictory, and changing requirements that are often difficult to recognize. It's very challenging for anyone, but it is most especially challenging for a government wherein government has weak capacity and is not sufficiently adaptive, responsive, and agile to respond to the changing situation. So the situation keeps changing as we go along, but our ability to make it through this pandemic will largely depend on our leadership and our government's ability to be adaptive, responsive, and agile. I think I will end here. Thank you very much.
Thank you, Dr. Ador. I'm sure everyone learned so much from what we've heard in from all of the speakers. We will now open the floor for discussions. If you have questions, you can click the raise hand button so that you can be recognized, or you may type your questions or comments in the chat box. We will extend for a few minutes to give way for the for questions and again discussions. And again, thank you to all of the speakers while waiting for questions. I was listening to all of the presentations, and there are three themes that I think run through all of the presentations. One is the friction between public health and the health of the economy, and then vaccination hesitancy and government mishandling of the pandemic and the other related issues and concerns. Okay, I think I'll have to ask the first question. So for maybe this is across all countries, no, in all. This is for everyone. Are there significant differences in COVID-19 cases across ethnic and religious groups? If there are significant differences, then why are this so? What may be the reasons behind such differences?
Sorry, was it across ethnic group? Did I?
Yes.
Okay.
Across ethnic and or religious groups.
This is talking about this whether there are differences. We are still in Malaysia. We face this problem of data transparency. You know, a lot of people, NGOs, and even some health experts, we have been urging the government to release more granular data, differences among different age group, gender, but so far no data on based on ethnicity. There are data based on citizens and non-citizens, but no data on in terms of ethnicity, and even regarding what do you call that, nationality. I mean, Malaysian or non-Malaysian, citizen or non-citizen. We do have that data, but I haven't really go into that, so I wouldn't be able to answer for that. But in terms of ethnicity, we don't have data at this moment. We do have differences across states because the health resources are not evenly distributed across the country. Some states are more poorly equipped in terms of health facility, especially in East Malaysia. It is a chronic problem for many decades already. Sabah and Sarawak, in terms of healthcare facilities, they suffer a lot. And then in the West Malaysia, you see states like Kelantan and Terengganu, the East Coast of West Malaysia. There are places where more poorly equipped with public health infrastructure. But in terms of COVID severity, it's actually Selangor, ironically, it is the most resourceful with public health facilities that is the most severely hit because of its population density. Yeah.
Yeah. To follow up Dr. Por's descriptions, similar cases also can be found in Indonesia. It is not mostly among ethnicity line, but among regions. In Indonesia's context, in the last few weeks, we start to see the sharp increase of COVID-19 cases in the hinterlands, including in the eastern part of Indonesia, including Papua and West Papua. And this is very worrying. I published an op-ed 3 days ago in the Jakarta Post and also in the Indonesian language in a newspaper about the need to see the increasing trend of the penetrations of COVID-19 into these marginalized and poorly equipped regions, particularly in the eastern part of Indonesia, but even among pockets in the western part of Indonesia, such as the southern part of Sumatra or the remote area in Aceh or North Sumatra, including among indigenous people. The largest number of cases, of course, in the densely populated cities in Java and Bali, but we also should take into considerations the higher number of testing. That's why I in my previous presentations, I took Spanish flu pandemic as an illustrations, not to forget the hinterland, because once the virus penetrate this hinterland with weaker health system, we will see most likely higher numbers of deaths and fatalities.
Okay, thank you for the answers. There is a question addressed to Dr. Ador Torneo. Good day. I will read it. Good day. This question is directed towards Dr. Ador Torneo. How does the economic and political priorities of the Philippine government affect the way health experts disseminate health-related scientific information to the public? Thank you so much.
Thank you for that question. In my opinion, there has been a lot of a lot of politics goes into the way that scientific messages are conveyed. Let's just start, for example, with some of the initial decisions on whether or not to impose travel restrictions and travel ban. We heard the health secretary saying that having a travel ban would be bad for diplomacy. So here you have a health secretary, health minister that's supposed to be making decision based on medical consideration, but the health minister was concerned about diplomacy. So it's a bit of putting the medical science or the medical concern behind the political consideration. And I think this has been also a consistent theme. Of course, it is understandable if the government would like to maintain public order, that the government of any country don't want people to panic. No? But at the same time also, government, especially health and scientific and medical authorities, have a duty and responsibility to disclose things from a medical and scientific perspective, because these are things that ordinary people do not have access to. But there is a tendency, especially in the last couple of weeks, before this surge of COVID-19 cases, we have one of the health undersecretaries, deputy ministers, arguing with one private think tank about whether or not the Philippines is going to experience a surge. And the argument is less about this information. They were arguing over the technicalities of the terminology, but I don't know. No, you call it by any other name, but what do we have right now? No, we can call it something else, but still a surge of COVID-19 cases. But I think the problem there is that in terms of communicating health-related and scientific information, we have not had a very effective communication strategy on clearly and calmly disseminating this to the public. So a lot of it might have to do with the way that the interagency task force is organized, but it also might have something to do with the competing priorities, including of the members of the agency task force. Some of those, their priorities are health. Some of them, their priority is security. Some of them, their priority is the economy. And that's why we cannot have one uniform message. Science and medicine is put in the backdrop. So that's my personal opinion on the matter. Thank you.
All right, thank you. There is another question, and I'm going to read it. Good afternoon, everyone. Thank you very much for the very informative presentation of our speakers. My question is, should we not now focus more on creating a national and general public health research facility for future purposes? For example, COVID pandemic. I think this is addressed to all of the speakers. Mr. Heng?
So easy. The easy answer is yes, because we need to invest in public health more, because that's very important to protect people's life. So in terms of COVID-19, we can see that a country like Singapore, which has a very good health system, I think that even have infection, but not many people die. But in less developed country with poor health system, you can see more people die from the virus. Yeah. Thank you.
But for maybe Malaysia or Indonesia or the Philippines?
Okay, maybe I'll say a little. Actually, in the case of Malaysia, we do already have a public health sector, very, very significant, and a sector that has been functioning effectively quite well. It has been repeatedly cited as a role model as well. But then this pandemic is really a test for us, in the sense that it is poor governance that lead to uncontrolled spread. Because if we talk about so-called path dependency, or the trajectory of this public health system, we actually share a very similar kind of system with Singapore, because both are previously British colony. So the system is actually same. Yet in this pandemic, because of poor leadership, that caused the collapse of the public health system. And ironically, at the same time, even though we have emergency proclamation, which is supposedly give the government authority enough power to acquire private health sector into this governing COVID-19, yet the government actually did not have any clear plan in acquiring the resources or using the resources of the private health sector, but rather allowing private health sector to charge exorbitant fee on COVID patients during the worst time of pandemic. So that's the very ironic part of our healthcare system. But in future, I think either remaining the same system or reforming it into a different type of system, which way is better, we are still debating whether or not to adopt the national so-called insurance, national health insurance, because that would be an entirely different system. That's a system more like South Korea, Japan, and Taiwan. And in terms of budgeting, that will be very, very different. That's my response.
Yeah, perhaps it is not just a national public health facility or research facility, but it is actually the investment the investment for preventive measures, and the investment in medical sciences for upstream level and also midstream and downstream level. What in the case of Indonesia, what we are seeing now is like the result of lack of investment in all those levels. We only have excellent facilities in Jakarta and other large cities in Java. Very few cities or districts who have key facilities such as PCR testing and including human resources who are able and capable to run these advanced technologies to support testing and to support digital tracing and also to support health promotions using digital technologies to provide appropriate or comprehensive informations for the public to enable them to differentiate between the correct appropriate informations compared to the hoaxes. So from my point of view, it is actually the keywords is investment. The country in the region should invest in these two things, science and also health system. And because there is no guarantee that COVID-19 is the last pandemic that we are facing in our lifespan.
I just like to add, yeah, I of course I agree that we should invest in this very strongly, and we've actually seen a couple of initial pandemics, no, since 2000. There were several. We were just lucky that all of them were managed before they got to the extent of COVID-19. I agree, general public research facility, but I would also suggest maybe also improving the collaboration between the different facilities, especially in Asean region. You know, exchanging information and researches would allow us to facilitate better and manage better the situation, because you know viruses don't just stay in one location. They could easily circulate around the region and around the world, and very important to have a strong regional cooperation also on the scientific front. In the case of the Philippines, though, the main concern that we have right now is trying to gather enough resources to make sure that the Philippine Genome Center, the one that does genetic sequencing, and the ones that actually does the testing, the Research Institute for Tropical Medicine, and the Philippine General Hospital would keep running. Unfortunately, the Philippine government has actually slashed the budget of these institutions. I don't know why in the middle of the pandemic and in the middle of the big surge, but I agree we should invest in this. But also, of course, we're trying to balance it. We want to survive the current situation, but we'd also want to make investments, because I'm very sure there might be other threats that are just within sight.
Okay, thank you. Another question. Since China is the main supplier of vaccines in ASEAN countries, how does such move impact our regional territorial tensions and stability? Anyone can answer. The question is from Marlon Quintela.
Yeah, can I answer that question? Yes. Because I need to go after the question, after the answer. I think yes, there would be a lot of impacts. Especially look at my country. During COVID-19, my country in China has shown kind of very close ties. Last year, my prime minister visited China, make headline during when COVID was very high in Wuhan city, and we visit there, and then later on we see a lot of help from China, mass diplomacy, vaccine diplomacy. And 10 years ago, when we chair Asean, we were criticized for siding with China, for people say we blocked the Asian communique when it comes to South China Sea. So this will because China support to Cambodia. I think a few months ago, our prime minister already said that if we don't rely on China, so who who would we rely on. So this is a strong message to show that our foreign policy might be, not might be impacted by our ties, our close tie with China. So this will have some effects on how Asian centrality and unity. Maybe next year when Cambodia hosts Asean, we will see what will happen. The influence of China might be on display next year. Yeah, let's wait and see. Yeah. So I need to leave because here it's almost 6:30 and I need to pick up my daughter from school. Yeah. So thank you everyone for having me, and have a good evening and enjoy the discussion. Yeah. Thank you so much.
All right.
Stay
Thank you
safe,
very much.
Yeah.
Thank you. Take care.
Yeah. Thank
Stay
you.
safe.
I need to go. Yeah.
Thank you.
All right. How about for the rest of our speakers? Would anyone like to answer, or should we? Okay, please.
Sorry. Yeah, I think the geopolitics definitely play out in this during this pandemic, especially through the so-called vaccine diplomacy. You can see that both the pro Western bloc of countries and the pro China bloc of country, and so it comes into play, especially in terms of offering free vaccines to poor country or countries that is encountering insufficient vaccines. But how is that really going to change further the geopolitics itself? I think it remains to be seen. Huh? Yeah, and it happens in almost a lot of places, including Africa as well, Africa and Asia. Yeah.
Okay, thank you very much. We don't have time. There are some more questions, but I think some of these have been addressed already by the presenters. I will pass the mic to Dr. Fernie.
Thank you very much, Dr. Katigbak Montoya. So on behalf of the Southeast Asia Research Center and Hub, the Department of International Studies, and the Department of Political Science and Development Studies, I would like to thank our speakers, Dr. Sudhir Manasir, Dr. Por Hyung Hong, Mr. Kim Kong Heng, and Dr. Ador Torneo, and our moderator, Dr. Evangeline Katigbak Montoya, for sharing their thoughts and their time with us for this webinar. To our guests, thank you for joining us, and we wish you a pleasant afternoon. Thank you.
Thank you.